Thank you, Mr. Chairman. Thank you all for being here. And there are people alive in the United States and around the world right now because of your companies and the work they've done with R&D, along with the National Institute for Health. And I fully acknowledge that. And I'm grateful to the people that are researching and working right now that are not watching this hearing because their face is in a microscope, actually going through things to be able to research today and what they're doing. With that said, as all of us have acknowledged that, we're trying to figure out the issue on drug pricing because people in my state, whether they're on insulin or whether they're on Parkinson's drugs or whether they're my own family or other people in my neighborhood, it's a very significant issue for them to try to figure out how to be able to manage this. So we've got to get to the bottom of how we manage this. All of you have mentioned the rebate issue has been a problem, and that insurance companies and PBMs are very effective negotiators. Part of the challenge of this is health insurance companies pay their PBM based on the quality of their negotiation skills, cutting a price off the list price. And so if a list price is higher and a rebate is higher, that also gives preference to them. So the difficulty is, as you raise list price and the rebate gets larger, the insurance company gives that preference, making it harder for biosimilars. Am I tracking this correctly? So the challenge that we have with this is, how do we figure out how to be able to break this down? Because we've got both insurance companies, PBMs, your companies that are creating the list prices in it, and then the biosimilars trying to be able to get into this. So, Mr. Frazier, you mentioned this in particular about biosimilars and the difficulty of trying to be able to break into the market. Why would you identify why it is hard for biosimilars to get into the market, which are inherently less expensive?
I would make two suggestions very quickly because I know you only have a little bit of time here. One is I think we have to educate physicians and other healthcare providers about the value of biosimilars. I think, secondly, it would be very helpful if we could relieve patients of their obligation to copay for the cheaper biosimilars. Those would be two specific recommendations that I would make.
Okay, thank you. I appreciate that. For the Part B drugs, those physicians are paid a percentage of the drug cost. So a biosimilar, when it comes into the market in the Part B world, is on its own less attractive to a physician because a physician gets a higher percentage amount prescribing them more expensive drug, which then feeds down to the patient and to the taxpayers, right?
That's correct.
How do we break that chain?
I think that there are many ways that we'd have to look at it. I don't have the specific suggestion here. I do think educating physicians is important here, and I think relieving patients, but we also have to look at the incentives as it relates to the ASP plus 6.
Maybe I can add.
Brother, please jump in because you had also mentioned this in your testimony as well.
I did, Senator, and thank you for giving me the opportunity. Let me give you a statistic that I think will present the magnitude of the problem. Here in the U.S., the penetration of biosimilars is much lower than in other places, but it is disproportional to different parts of the U.S. healthcare system. For example, in open systems that the decision maker, it is a PBM, one biosimilar that we are having has a market share of 5% in the U.S. In closed systems, in systems like Kaiser, for example, where they're integrated healthcare systems, where the one who decides has the whole cost of the healthcare system in its interest, we have 73%. 5%, 73% for the same product. I agree with what Mr. Fraser said, that we need to create incentives, but I would add also that we need to break this rebate trap that creates significant disincentives for providers and the healthcare system and insurance companies.
Anybody else want to jump in on that?
I can give you an example, Senator. The insulin market has a reputation not to be very competitive. In fact, it is. And we have biosimilars which have reached the market and have grabbed a very significant market share. We believe that when insulin would not be treated as drug, but would be considered as a biologic and be submitted to biosimilar regulation back in 2020, the biosimilar market share and penetration would be even higher.
Thank you. My state in particular is working very hard on our Medicaid side, on working on value-based pricing. I know that's something that several of you have mentioned before. It is the grand challenge of not pricing a drug based on it would be more expensive to do surgery, and so we want to be slightly under the cost of surgery. We do have to be able to break through that model. Of course, surgery will be more expensive than most of our treatments, but I think there is a benefit that we continue to experiment with. If the drug is being effective, then we have a reducing price on it, and we can get a chance to be able to work through through that, as we have done in our state. So
We would support that.
well, we'll continue to be able to work through other creative mechanisms. At the end, we can't just have the taxpayer pay more, but the consumer pay less, because that's really a consumer still paying, just it moves to another spot. Mr. Chairman, thank you.